Yeah, first and foremost, important thing in this is, or in dementia assessment is, first is the clinical assess interview, then it comes behavioral observation. Then we have a lot of standardized assessment tools for that, like Behave, AD, and then otherwise we use Addenbrook's examination thing. That is another one. But all these things, whenever we use the basic concept, whatever we have learned or whatever we have seen in the books, is the majority of the assessment or whatever we do, the behavioral observation of the patient is much more important than we talk about the other things, because there are times when because in BPSD, basically the first line of action is to help the patient with the non-pharmacological ways and means. Where it comes that we have to understand what exactly the patient is going through and what are his problems are. Let's say when we talk about the behavior, let's say we talk about the cognition part of it, let's say we talk about the emotion part of it. These three are very important aspects where we consider when we assess the patient. Because when you assess the patient, because unless we do these three parameters in a detailed way, we may miss certain things which may not help us in the long procedure of this patient's review or the prognosis. So these are all major important aspects. First and foremost important, what here comes is when we use an Addenbrook scale, it gives us a clarity on all the symptomatology of the patient, and that helps us to bring about a change in the patient, as well as it helps us in the treatment program as well.
Uh, if a diagnosis has already been made, they can be seen by a psychiatrist to start treatment for dementia. If that has already been done, they can also be seen by a psychiatrist for any of these behavioral symptoms that we just discussed. That is in the remit of psychiatry. Management of behavior, management of psychosis, management of mood is in the remit of psychiatry. So we would be able to help the patient and the family in those aspects. I can't emphasize enough what Dr. Thomas said, that first, non-pharmacological, meaning non-medical management, is the first line that has to be looked into first. And if that doesn't work, we move to medication. Even in medication, the first thing we would like to give is, if the person is not on any treatment for especially Alzheimer's dementia, there are two different types of medicines that are approved and are available that we can give first, which have shown to have some evidence in managing these symptoms. The first one are called dementia. It can also help delaying the progression and keep the patient independent longer, rather than move into a nursing home or being needing to be cared for 24/7. So that would be the first line. Along with that, another medicine called memantine that also has shown to help with agitation, help with depression, help with sleep. So if there are such problems, the first thing would be to give these medicines, because they have dual role. They help with treatment of dementia. They also help with treatment of behavioral symptoms. We have various options. It depends on what type of behavioral symptom the person has. For example, if they have depression, can try antidepressants. Antidepressants can also, some of the antidepressants can also help with sleep, can also help with agitation. For example, if we take mirtazapine can help with sleep, can help with appetite if you're not eating well, along with help being an antidepressant, so helping with depression. It can also help with agitation, calm the person down because it has that calming and sedating effect. So that's something we can try. There is also evidence that other antidepressants like sertraline, citalopram can help with agitation in people with dementia. They can also help with mood. These would be the some cases the agitation can be sorry.
Yeah.
No problem. If you have a question, please continue. I can continue later.
Yeah. Yeah. These are very simple, but same time very complex, and at the same time very critical ways of handling with the non-pharmacological ways. First and foremost, important what we look at this kind of scenario is like creating a calm and a structured environment. That's a very important thing in this BPSD because it can reduce anxiety of the patient. Then we have something called as engaging into meaningful activities like music therapies can be one way of handling the patient to help him to reduce his restlessness and all. Then we have something called as reminiscence therapy. What we normally do in this, like patient, we help the patient to discuss about his past experiences and all. That means what we are trying to do here is to recall and share a positive memories of his where he feel the boost. He feel the boost that yes, I did something in the past, so I'm good. I can do this. So this reminiscence therapy works very wonders in so many patients, that which we have seen in our experiences as well. Then comes the validation therapy. In this therapy, what we do is normally is like one working through the unresolved conflicts. That means we try to understand the patient and acknowledging the person's feeling, even if they don't align with the reality. Because we want to accept the patient, because he might have some issues going on with him, but the acceptance of the point what the patient is making, if even if it is not aligned with the reality, we need to go with that. Then comes something called as stimulated or simulated presence therapy, where we help the patient with old records of his family functions or old records of his family members and all, where the patient can relate that that point of time I have discussed this, that point of time I discussed that, so that he can improve on his presence, where he can help out with his own voice, or he can just make sure that this is what I used to speak, this is how I used to put words forward. That is one. Another one which normally help the patient is an aromatherapy, where we can use all this fragrant plants or oils, which a patient will be much more happy because these people lose that texture feeling, or they lose that nausea kind of thing which happens to them. So those things will help them to understand what exactly is going wrong with them. Then we do a lot of sensory stimulation programs where we're providing them with a calming music, providing them the textured objects to touch, to feel and understand what exactly they're touching and all. And it helps them to understand what exactly is they can how they can be stimulated through these kind of texture objects and stuff like that. Then we have something called as cognitive training and rehabilitation. What we do here is try to understand the cognitive deficit. Normally, when we do this ACE Edinburgh, we've come out with a lot of patients who have only MCI. What we call MCI is, like we all know, MCI is a mild cognitive impairment. So there are times we may not need a complete treatment program. We can just help him with certain things. So but we when we come to a cognitive training and rehabilitation, it comes with all the other allied health care, which is like we talk about speech therapy, we talk about occupational therapy, we talk about sensory integration therapy, we talk about all the other things, physiotherapy and all. Then there are few cases where they have seen the effect of light therapy as well in the management of or in helping a patient with these kind of issues. And there are some studies which talks about even acupuncture, but I haven't used it. I have not idea about it. But there are some studies which we have gone through, which we found that some acupuncture is also helping patients with having a dementia.
As far as possible, I think both the speakers have clearly told that the non-pharmacological methods of treatment will be the first choice in most of these behavioral problems. What is to be needed to understand here is what we adopt, at least I adopted what was the PCP program, person-centered program. We can't generalize all the patients with the same sort of a plan. So each person needs to be understood and a separate treatment plan has to be drawn. The second important aspect in understanding the behavior is a lot depends upon how you educate the carers, the immediate carers. A lot of times their expectations are quite high. When you say we are going to manage this behavior, whether psychologically or pharmacologically, whatever it is, their expectation shoots up and they start demanding more of things. The patient's carer's education is a very crucial thing. In this context, I think it is worth mentioning that the carers group meetings are very essential and very useful because the families interact with each other. Each family puts up a problem of their own and how they resolved it. And there is some learning from others' experiences to the next patient. This sort of a thing usually helps a lot in managing these things. And as Dr. Sudha was mentioning, there are different types of behaviors which affects mood, sometimes it can be psychotic behavior. But one thing which is very essential is the medical aspect of it. I would touch a thing and probably Dr. Sudha will elaborate on it later. Unlike the regular psychiatric disorders, we can't keep on administering the medication endlessly. So, because the symptom pattern is very variable and keeps changing over a period of time. If I see a hallucination today, probably I may not see a hallucination after 4 weeks or 5 weeks. So we have to adapt to that sort of a thing, evaluate them more frequently and adjust the medication. And these strategies will be helpful. I think Dr. Sudha will touch upon it later. And this is my sort of observation. Thank you, Nitin.
The actual treatments for dementia, which is donepezil or memantine, they can continue as long as the patient can take them and they're tolerating them. But the treatment specifically for BPSD or behavioral and psychological symptoms, as Dr. Chandrasekhar mentioned, they need to be reviewed quite regularly, especially if you are prescribing something called antipsychotic like risperidone for management of agitation or aggression. It definitely needs to be reviewed monthly or at least every 3 months to make sure if it is required. Most of the guidelines don't recommend continuing antipsychotic for long periods in these people because they are known to cause serious problems. So we need to be very cautious about giving them, but also cautious about trying to stop them when they are no longer required. And the symptom profile keeps changing, so we need to look at, is this something that can be treated with medicine? If so, is it necessary to treat it? Can we manage it without treating it? Is it causing any harm to the patient or to the family? If so, yes, treat it. If not, maybe we can wait a bit and it will subside by itself. If we are treating it, how long should we need to continue and when do we need to stop the medicine? So these are the 4 points that we need to keep in mind when we are starting somebody on any treatment for BPSD, especially antipsychotics and sedative drugs.
Your favorite method. Your Mysore Pak.
Yeah, I haven't got you the complete question because I think I was in between, some disturbance was there. Hmm. See, first and foremost important thing is normally what we call it as acceptance and harmonize with the patient, or adjust, acceptance and adjustment. These are the two words. If a caregiver is there, if he has these two words in his head, I think the half of the issues can be sorted, because it's tough. We know that it's going to be tough, as Chandrasekhar sir was rightly saying that all the dementia patients are not same. So there were a lot of behavioral issues with them. So, how to handle those temper tantrums? What this gentleman is doing? Because in Hindi, I think all of us follow Hindi. So, Pachpan and Bachpan is the same. So, when you talk to this gentleman, this Pachpan, he behaves like a Bachpan, he behaves like a child. So, that point of time, you have to handle him like a child. If you do that way, I think he will understand few things, and then the caregiver also will be. See, for example, in a class of 30, 40 students, when the child is doing a lot of galata, you make him a class monitor. So obviously the teacher is making that tiger in the class as a kind of a fox in the class, or something like, who can manage the class. So what happens is, this way also, if you just help the patient to understand that this is what we are doing for you, this is where you will be helpful and all. The caregiver once takes some extra effort in helping the patient, then he don't have to work hard behind the bar to help the patient to take medication. So few things, if because if you understand that, for example, let's say, I just give you one simple example. This gentleman, he was around 77-year-old and is a military retired gentleman. He's a brigadier in the army. His problem was he cannot take commands, he can only give commands. So now that was in his blood now. So the problem is, he will not listen to the doctor, he will not listen to anyone. He listens to only one gentleman. He is there, he's his driver. So what we did is, with the help of the driver, we tried to help this gentleman, saying that you give him, and we will be able to give him some medication. Otherwise, he is not ready to take anything. Slowly is responding to the treatment, as well as the behavioral, pharmacological treatment, as well as the psychological therapies what we try to give it to him. The problem here is, the more we show the agitation and the more we show that aloofness, this patient will not respond. This has to be like something what we call as a hand holding thing. If that hand holding thing happens here, most of the patients can be taken care of, and they will take their medication.
There are many different medications and each of them have different side effect profile. Do you want me to start with each one, or how would you like to do that? Right. So loose motions. Yeah. For memantine, they can have constipation, so they might not be able to pass stools. They might feel a bit sedated, and it can also cause falls. So that we need to be a bit cautious. So it's better to give it in the night time. Coming to antidepressants, it depends on the individual antidepressant. If you look at SSRIs like sertraline or citalopram, they're usually relatively safe, but they can cause increased risk of bleeding in people who are already taking any anticoagulant or aspirin or any other drugs that prevent blood clotting. And they can also cause lowering of sodium in older people especially. So if they're already on diuretics for blood pressure, it might be a problem. So we need to be mindful of that. Whereas if we come to antipsychotics, which are the ones that we usually give if they are very agitated, like risperidone, they can cause increase in weight. They can cause, some of them can cause sedation. Some of them can cause tightness in limbs, in arms and legs, shaking of hands, difficulty walking, but that is only at high doses. So if we are cautious in giving it at low doses, it might not happen. But the most serious side effect that can happen is they are known to increase risk of death by stroke. That is why it's very important to give it for shorter periods and review it again and again. And in some cases, we also give sedative drugs like benzodiazepines, lorazepam, for example, and they can be, as the name says, quite sedating. So they can cause sleep, they can cause drowsiness, they can cause falls. But again, it's balance between what is the behavior, if the behavior is serious enough and that needs management, and if the patient is at risk because of the behavior itself, it might be worthwhile to treat it at appropriate doses, review the doses regularly so that they don't have side effects for long, and if necessary, stop the medication as soon as they're not needed. It's a very important question. So with regards to medication interaction, as I mentioned, with antidepressants, any medication that prevents blood from clotting, aspirin, clopidogrel, warfarin, or other anticoagulants, there is an increased risk of bleeding into the stomach or into the brain. So that needs to be kept in mind before prescribing. Most of the time, we also give another medication to prevent bleeding into the stomach, like an omeprazole, to help with that problem. When other interaction with antidepressants is diuretics, medicines that increased passing of urine in body, that is given for people with blood hypertension. They can cause low sodium, and antidepressants can also cause low sodium. So both combined, the risk will be higher. And if they have low sodium, they become confused, they become jittery, they can have falls, they can look very weak and tired easily. So, and they can have giddiness. So this needs to be kept in mind. With regards to antipsychotics, some of them can increase blood sugar levels. So if they already have diabetes, that can be a problem, but only when given it for a long period. It usually does not happen in the short periods. They can also increase weight again in long period. So people with diabetes and hypertension, if they are taking some antipsychotics, not all of them, some of them, the levels might change. But we also need to keep in mind that these people are very old. They already have dementia. So we need to balance that, keep that in mind, and balance the risk of momentary increase in blood pressure and blood sugar now versus a severe behavioral problem that can lead to more problems in the long run. So that we need to keep in mind. So in short run, they should be all right.
Okay. So if you want to so we have many scientists who are also there. So what do you think are the hierarchy are reliable or before medication you can give other.
That's a tricky question because we need to be, as Dr. Chandrasekhar mentioned, it's a person-centered treatment. So we need to look at what other medical problems the person has, what medication the person is taking before we decide. But in general, when it comes to antidepressants, if the person is not sleeping and not eating well, mirtazapine might be a good choice. If that is not a problem and sleep and appetite is not a problem, SSRIs can be a good choice. With regards to antipsychotics, the only antipsychotic that is approved for this indication of agitation and dementia is risperidone. But we do try others if we can't give risperidone for whatever reason. So there are other, we can try olanzapine, we can try quetiapine, we can try aripiprazole. But the approved one is risperidone. And the only one that is relatively better than others is lorazepam because it is short acting. Others are long acting, so it might be risky to give in older people. If it is just for sleep, what we call Z drugs, zopiclone, esopiclone, those might be better than actual benzodiazepines.
Now father or the mother. Now what the caregiver is different. As man said, there might be some interaction. So they try to control everything. It gets so stressed that they have the work stress, the family stress a lot. So how do you manage such kind of caregivers? Few of them are very cheap. So a lot of people will have a lot of doubts. Part is only counseling of caregivers. So basic things you said yes, something. What are other ways caregivers manage themselves?
Hey, your voice is breaking. I couldn't got the complete question.
Yes, sir. So how can a caregiver who has a lot of stress about their family and their now is here, behavioral issues. So they are also under a lot of stress and they want to control how to manage caregivers and as a caregiver what you should.
Yeah, as we are discussing about that medication things, here the foremost important thing is a patient having behavioral problems when we're giving them, let's say that we are giving them a medicine for dementia, or let's say that we are giving the medicine for behavioral problems. The caregiver must be trained or must be spoken to, as Chandrasekhar was rightly saying that there should be a meeting with the caregiver so that they will be able to, like, for example, when you talk about Alcohol Anonymous group, we talk about these things. So even dementia also, there are a lot of patient caregivers who themselves have a lot of issues with their caretaking and all. So once if this people meet each other that this is the medication has been given to me by so and so doctor and it is helping me, that word which is told by someone that yes, this medicine has helped, that can do wonders. Because if at times as a professional we try to tell them, it may not be that effective. But if somebody who is already using this medication and once he put his experience forward, I think the caregiver will be accepting the medication more compared to what we are as a professional we are saying to them. That's one. Second one is in this scenario is we need to make sure that the patient caregiver should be given a proper knowledge that this will happen. As Dr. Sudha was talking about the side effects, this will happen, but it's not necessary that it will happen in each and every patient, the side effects. So all these things, if we are giving the education to the caregiver, these things can be sorted, because that's where that the relationship between the patient, the caregiver, and the doctor comes into play. And when these three people are sync, they have a good sync, then the treatment for this BPSD is much more comfortable, as even this is mentioned in the studies as well. If the three people are able to sync together.
Can I say to being
One thing which I would like to add here is that most of the clinicians inadvertently, we do it in our routine practice or not with any intention. Sometimes we always tell the patient or send the patient outside and discuss the management with the relatives, thinking that anyway he's having dementia, he's not going to understand anything. I think that is a false notion, because the amount of cognitive deficits varies from individual to individual. A lot of times they may be understanding but unable to express their views because of a language problem, because of the hearing problem, whatever it is. So always the deficits, cognitive deficits are patchy. They are not uniform. So it's always better to keep the patient along with the relative and discuss the management. And this partly they will understand. And somewhere they understand that the doctor and the carer are discussing about him. Otherwise, sometimes they become too suspicious and don't cooperate later. This is one factor which most of us have to remember, especially when we are dealing with mild to moderate dementias. Severe dementias, probably they may not be able to understand. The other important aspect is the emotional sort of memories are much more for a longer time. Though they may not be able to identify a person, the same person, son or daughter or whoever it is, comes and sits with them and touches their hand or hugs them, they immediately realize that this is someone who is close to them. They may not be able to tell their name. These are the things which we see. Regarding personal experiences, I think there are multiple experiences, but a lot of times we have to be a little bit innovative when we are offering a solution to a problem, especially with BPSD. So sometime I remember this very well. One of the patients was refusing to enter into the bathroom or the toilet. And the carers were not able to understand why he refused. Till yesterday he was going into the bathroom. Today he stopped and saying that I cannot enter that room. He was refusing vehemently. Then we inquired what was that thing which happened. The only thing which has happened was a doormat was changed the previous night. And somehow the design on the doormat was threatening the patient in some way. Then we said, let us try this, remove the doormat. Immediately the problem was solved. I mean, there are a lot of innovative sort of solutions which you have to make. Like someone is not eating. So usually they don't eat at a stretch. Sometimes they have the habit of gulping morsel and then leaving it there and going off. And another intelligent carer, what he did was, wherever the patient was wandering in the home, he kept small parcels of food. A biscuit there, a small morsel of rice there in different plates. And whenever the patient used to go to that place, she used to inadvertently put that, gulp it, and the problem of eating was solved. So we have to evolve innovative solutions, and especially with reference to the toilet needs, eating. Eating is one of the difficult things. Often we have to space it out. We can't expect them. The other thing, when they don't open the mouth and eat, what we suggest is use it along with the patient, and you also start eating from your plate. Sometimes they mimic your actions. So these are the things, several sort of a thing when we're having the problems. We have to train the carers, we have to train the family members in all these things. We have to think innovatively. This is where the carers meeting helps. Each one comes out with a solution, how they handle the problem. I think this is my experience over the last few years. Thank you, Nitin.
Thank you, sir. So the one more thing come with what Varun said, problem. The majority of the people they have a lot of sleep issues. Sleep more during the day cause a lot of issues. And also, as you said, few of the medications cause drowsiness. Some patients might have diabetes. They might be drowsy when they get. So how to handle this sleep?
Thank you, Nitin. The sleep issue, if they're sleeping more in the day and not sleeping in the night, first thing to do would be try to keep them awake in the day by engaging them in activities, involving them in their own hobbies, or doing something so that they don't have too many afternoon naps. With that, most of the time the problem might be solved. So basically, what we call sleep hygiene, various, if they're drinking too much coffee or tea in the evening, things like that. But after handling all those, if the problem still persists, because it can become a habit after a bit of time. They continue to have that cycle altered, so they keep sleeping in the day and not sleeping in the night. First thing we can try is melatonin, because it's known to indicate the brain that it's time to go to sleep. So we can try that first, see if that helps. This drug can also be useful in people who have other problems during sleep called REM sleep disturbances in some kind of dementia. So it's relatively safer than other sedating drugs because it's a naturally occurring hormone in the brain. So that can be tried first. But if that doesn't work, we can try medication for sleep, but they have to be given for short periods. That's really important to remember. So the idea of giving the medicine to help with sleep is to change the habit of sleeping in the day to night time. Once the habit is formed, the medicine should not be required anymore. So if they're properly engaged in the daytime, they're alert in the daytime, and they're provided the right environment to go to sleep in the nighttime, that habit changes to sleeping in the night. So it takes a bit of work from the family as well, but it can be done.
Thank you, madam. John, sir, what are the non-pharmacological ways for like a lot of the people that addictive, so they may not be willing to give, so even though the doctor, the psychiatrist, the caregiver may not be willing to give. What are some non-pharmacological ways which
Yeah, see, as I already said that we have this reminiscence therapy, validation therapies, and simulated presence therapy or aromatherapy and all these things, whatever I said. But all said and done, basically, if we are able to communicate, adjust, and have a feeling of acceptance, those three things, four things will help us in managing a patient. That is one. Second one is like if we are able to encourage the patient for having to do with some kind of a physical activity or some bit of exercise, or because it will help him to get rid of or maybe reduce his agitation and improve his sleep. Because if we do some bit of physical activity, because all the dementia patient may not be like disturbed. So let's say that the mild to moderate, we can tell them to do certain bit of activities where they can help. For example, maybe going for a walk. You can also join with him for a walk, maybe in the vicinity of your home premises as well. That is one. Other one is like basically they look for majority of the time they look for something to do with the validation. If, for example, just now Chandrasekhar sir rightly mentioned that the moment the food mat was changed, he was not willing because he thinks that something is they are trying to do something with me, because that's the reason they just changed it, because that's where we found this patient that when they have issues with the textures. So when that mat is replaced again, the same mat, he was fine. So that way, a lot of things we have to understand with the way he's presenting to us, the way he's talking to us, and the way he's expressing his feelings to us. If we are able to do these things, I think at a long way, because this is not going to be a 1 month or 2 months thing, it will be a long standing problem. So we need to be very much cautious in talking, in expressing, in putting things forward, and helping him to understand that this is what we are here to help you, to understand you, we accept you as a person. So that is something which is majorly important, because these things, let's talk about reminiscence therapy or validation therapy, simulation therapy, aroma therapy, what all things. But patient understand, as again Dr. Chandrasekhar quoted about this touch. A touch he might understand, and the talk what we are talking to him, he might understand that. The comprehension what we're trying to explain to him, this he might understand. So all these things put together, that once a caregiver who is an important significant member of that caregiving role, if he is able to understand the patient fully, thoroughly, like this is how he likes, this is how he eats, this is how he talks, this is the time he goes to bed, this is the time he goes to the bathroom. So all these things, if we have a clear cut made a chart kind of a thing, this will be much more helpful for a patient with dementia to be taken care of. Because most of the times what is happening is, even the caregiver also feel the pain that what he is putting, what he's undergoing. So at times he also come into some kind of an argument, and when he don't like things, so those things also we have to tell that this is a patient, you have to understand as a patient and help him as a patient. But if you do that, he will, there are chances that his problems will improve. Like means his deterioration thing will improve, it will not accelerate, it will actually decelerate, where you will also feel happy because your prognosis is going in a good way forward. Like that we can help the caregivers as well as the patient.
Okay, sir. What will you tell the team who already, like we have seen a lot of cases in which the beats the he doesn't like, they beat the patient with not listening, or they themselves are. So what is your like your
See, basically, the patience of caregivers is always testing. We have to actually sympathize with them too, because they will be under a lot of stress. Angry outbursts now and then is okay, but I don't think many would really resort to physical abuse. Most of the carers don't do that. Sometimes they may do a physical restraint by tying up the patient if he's not sleeping well at night and constantly disturbing. So this is where the clinician should probably address that issue, especially with reference to sleep. I think Dr. Sudha already mentioned what to do about the sleep problem with medication. But a small addition to that is, if you are giving melatonin, give it around 5 o'clock. Don't delay it till 9 o'clock or 10 o'clock. Give it at 5 o'clock so that the melatonin effect peaks during sleep time, and give a jet drug like zolpidem around 10 o'clock. Practically, this has worked very often. The other drug, which often, not very often used by most of the clinicians, but it is recommended, is gabapentin. Give 100 milligrams of gabapentin day 1. If not adequate, give 200 day 2. If not adequate, give 300 day 3. If 300, the individual doesn't sleep, then stop it. It is not going to work. So this is one thing which one can try. I mean, just sedation alone will be, sometimes if we use other benzodiazepines to sedate the patient, like nitrazepam or diazepam, it will make the patient more confused and he becomes more restless. So either choose a short-acting benzodiazepine or zolpidem or gabapentin. Mirtazapine are other drugs, but I think physical abuse by carers is not very often seen, because we do see when they bring the patient for the follow-ups or when we make a home visit. The another important thing which probably is needed in the care of the dementia is making home visits. Home visits always gives you a lot of information, which you don't get in a clinical in your office when you are seeing the patient. I think both Dr. Sudha and Dr. Thomas has covered a lot of things and elucidated a lot of things. I think there's nothing more for me to add.
any real life would like to in
About what? About what issue?
About a patient with dementia.
One family which I remember quite a lot, which was in the initial days of my practice with dementia, is that this a very high ranked engineer. He was one of the topmost engineers in the state. He came very early, in fact, and somehow it looked like depression, and we treated for depression for a couple of years, and then gradually we found the cognitive changes. The family, the wife was throughout with him, and the amount of the patience and the care which he had was astonishing. In fact, I used to make regular home visits to this family, and the way he deteriorated over a period of about 8 years was something revealing to me, where I understood a lot of problems which the carer undergoes, both emotional, physical, and a lot of other things, which financial, in fact, a lot of the ordeals they go through. So the carer's burden has to really be addressed. In any situation, we shouldn't take it light. Sometimes when they come for follow-up, they spend a lot of hours trying to explain their thing, and we shouldn't say that. It's a time-taking process. Generally, caring for dementia, trying to educate the care is a time-taking process. One should be prepared for that. It is. See, I always say dementia care is not clinic-based or hospital-based. It's community-based. It is home-based. Unless you are prepared to do that, there's no point in involving yourself with the care of the dementia patient. That's my take on this.
It's a very good. Any used
In the UK, we go with tried and tested. Usually, drugs for to be approved by NHS takes a bit of time because it's all government money. It's as problematic as it is in India about that. But there are some medication that are, I think, available in India as well, like pimavanserin, which is something that is supposedly more safer for people with Parkinson's disease dementia and Lewy body dementia for managing psychosis. I think that can be. But it's an exciting time in dementia care at the moment because there are many trials happening on disease-modifying medication that are getting very close to approval. One has already been approved in America, aducanumab, but that's a bit controversial, so let's not go into that. But it's an exciting time. There are many disease-modifying drugs coming up, so we might see curative treatment soon. How easy it would be to roll it out to general population, how much cost it would take, what facilities need to be there. Those are the logistical issues that are present, but at least if we have something, then we can look at logistics, I think.
any take-home message or caregivers?
I can't put it better than Dr. Chandrasekhar said, because it is a team effort. It is something that needs to be done at home, involving the caregiver, involving the patient. So diagnosing as early as possible will help with accepting the diagnosis, understanding what changes might occur in future, and plan for them properly. And that would reduce caregiver burden to an extent, along with all the other measures Dr. Chandrasekhar mentioned. So it's important to get the diagnosis and see a neurologist, a psychiatrist, it doesn't matter who, but see a doctor, understand what is happening and get a diagnosis and start treatment early so that changes can be looked at soon without it becoming chronic and without it becoming a major problem.
Thank you. Johnson,
Thank you.
Yeah, because it is something where it's an experience. See, for example, when you work with a dementia patient, it's literally tough because when he comes to you, maybe he might be coming to you for third or fourth time. Sometimes he don't even recognize you. There are some patients like that. So even they don't even recognize their loved ones also. So what I would suggest as a last statement, whatever we can make here, as whatever we discussed, I think those are the very important or valid point which is there in the long run, which will be very helpful for all of us, or maybe and for the caregivers as well. But the one and the foremost important thing in my experience with dementia patient, which I have been trying to see with most of the patient is like if the patient and the caregiver and the doctor are able to sync, as I think Chandrasekhar sir rightly quoted that it is more than clinic treatment rather than a home treatment. So once you go to the home and maybe home visit, that may give a lot of understanding of the problems and all. You will exactly know what this temper tantrums are or what are the behaviors are happening around. So if we say that we are totally into this treatment, we are helping the patient in whatever ways or means possible, and we are there for you. If that is understood by the caregiver, I think most of the chunk of the problem will be sorted. That's we are there for you. We will treat you well.
Okay, sir. Thank you very much. Is any NMC interested it on your help help for me one of like to who would like to thank the person now? I would like to hand over it to this this who will be in the panel. This is the immediate immediate support you.
Thank you, Nitin. I think already the conversation which has gone on so far, the talks by Dr. Sai Sudha, Dr. Chandrasekhar, and Dr. Johnson have laid the ground for the next aspect of the discussion, which my fellow panelists we are going to discuss about, and that is the problem of the caregivers who are taking care of the patients with the Alzheimer's dementia. It has rightly been pointed out by Chandrasekhar that it's very difficult for patients to take care of to be taken care of. There is the stress of the financial stress, there is the emotional stress, there's the stress of having to take care of a person who's deteriorating before your very eyes, and that leads to a lot of burden on the caregivers. So along with the epidemic of Alzheimer's which is unfolding in a country as the country ages, we are also having a subtext here of an epidemic of caregivers burnout. Now, burnout, as you all know, is a state of sheer physical exhaustion, emotional, and physical exhaustion, emotional as well as mental exhaustion. This leads to impediments in the care of the patients with dementia themselves. And so there are several aspects to this which need to be discussed. When we are talking of caregivers, let us bear in mind that we are not merely talking of the caregivers who are living with the Alzheimer's patient and having to take care of them, but also the professional caregivers, people who take care of Alzheimer's patients as a home service. There are a lot of people who are being offered now. A lot of services are coming as home service for patients with dementia, where the family members are not able to take care, or they do not have the persons available or the capacity to take care of the older persons. So caregivers, professional caregiver burnout is also an important issue that we need to think of. And if you want a proper care for the patients, we need to address the problem of the caregiver's burden also. As this is something which needs to be taken care of, not somewhere down the line after the burnout has occurred, but this is something to be kept in mind and initiated at the time of the first contact with the psychiatrist or the concerned physician or psychologist who's going to take care of the patient and who's going to give advice. In advance itself, if you realize that this is inevitably going to happen and address this right from the time before it even happens, that would be a nice way to take care of the problem. So with me, my fellow panelists are there. Dr. Pawan. Pawan is going to talk about the different symptoms and recognition of burnout and also the stress in the caregivers. George has volunteered to discuss about the rural-urban divide, which is a very important divide because it has been known that the stress effects on the patients with Alzheimer's, a lot depends upon the education level of the caregiver, the knowledge of the caregiver, the emotional resilience of the caregiver, the support system that the caregiver has got. And so there are a lot of differences in the different cultural scenarios, which George is going to talk about in his great wisdom. And then we are also going to have Dr. Rajshekhar, who is going to talk about the interventions that we can do as a preventive or post-hoc when the problems do arise, the interventions that are going to be done in the course of the care that the person is, the problems that the person is having. So, Dr. Pawan, over to you, please. Pawan, are you here?
Yes, sir. Am I audible, sir?
Yeah.
Sir. At the outset, I thank IPS TSB, Office Bearers, and ARDSi, Hyderabad Deccan chapter, and Aster Prime Hospital. This is a unique opportunity for me, and this is a nice partnership. So, coming to the caregiver issues, so it's most of the caregivers, though they say that there are some caregivers who may have a positive effects of offering care, but then the negative effects of the caregiving is one which catches the most attention actually. So often these patients are called as second patients or co-patients. The reasons, as has been the talk of the day that Chandrasekhar sir has mentioned, and even Alinjandani sir has just sorted it out. It can be patient factors or it can be a caregiver factors. So we need to see what understanding does the caregiver have about the illness, and what is the expectations of the caregiver, and what is the social support system that he has. It plays an important role. And not only that, the cultural aspects, because here in this part of the world, we believe that caregiver is expected to don many roles. So not just offering a treatment or taking to a physician, and the society also looks, you will be having a very keen eye on how the care is being provided to the aging person. So even the kith and kin or extended relatives, they often come and have these conversations with them and expect them to do everything that sometimes may not be possible for them to address. So these are some of the things that play a very key role. And then apart from this, the patient factors or the dementia, if you see the per se the dementia effect on the burden on the caregiver, it is not so much, but the behavioral and psychological symptoms of dementia contributes a major chunk to the caregiver burden. And apart from this, the medication side effects or the comorbidities that they have, these are all important factors, whether the managing the activities of daily life. As Chandrasekhar sir was giving the example, like Chandrasekhar sir's example, though it may be very trivial issue for us, but when we see from the patient perspective, it has brought a lot of change, even the doormat thing. So such issues, even the appetite issues, not consuming food, all these things, they really contribute a lot to the patient. And in what way does it affect the caregiver? So because of having to do so many jobs and attending to all the needs of the patient, their life is having a compromise. That is, they are not able to perform their duties to the optimal level personally. And the age of the caregiver is also an important issue, because different age groups have different roles and set of expectations that their families, from their family and society. So because if one is engaged in the care of a person with dementia and also having a behavioral and psychological symptoms, so they may have to cut down on their work and or probably change their jobs. And now, apart from the usual burden that care has, their income is also coming to a compromise here. So it's a dual financial burden on the caregiver. And then not only that, the expectations of the caregiver is also an issue, because if they lack the complete knowledge and what to expect, the magics or miracles doesn't happen here. The prognosis, we know that it's a down ladder thing, but then we can only delay the inevitable. And that if that sort of knowledge is not there to the caregiver, and if they are expecting, so this expectation and not able to have the results might well precipitate more stress. So what happens when the caregiver is stressed? So there's social isolation, and then they will not be able to attend to their routines, and they may have agitations, this may further worsen their general health conditions, where they will be more prone for having a medical illnesses, not only medical illnesses, even psychiatric illnesses like depression and anxiety. These are some of the problems that are more commoner in patients, in caregivers who are attending to patients with dementia. So, as sir said, it's not just one person's job. It's a collaboration is required. Where we can have whenever there is a need or there is an issue that has to be addressed with proper advice and medications. All these things, they definitely are needed to have this. And then only when the care is comprehensive, and even the caregiver, unless caregiver is perfectly healthy, they cannot provide a good care to the patient. So
yeah, thank you. Yeah, thank you, Pawan. In other words, what you're trying to tell is that we need to educate the caregivers about the course of the illness and what to expect in the course of the illness, and also you need to prepare them to handle problems as and when they arise.
Yes.
Yeah, thank you. It's a very important point you have mentioned. Can I call upon Dr. George to give his take on his experiences with caregivers from different backgrounds and different cultural scenarios?
Sure. Sir, at the outset, sir, I thank you, sir. I thank the IPSTSB and the ARDSi Deccan chapter on Dr. Chandrasekhar sir's guidance, and Aster Prime, Dr. Nitin and Anup. You definitely need a special applause for a wonderful activity. And at the outset, sir, first I would like to thank Chandrasekhar sir for his passion for the geriatric psychiatry, particularly the dementia related. And I think we have learned a lot from sir. Sir, the respected moderator, Chandani sir. Sir, I think I would like to talk from my experience, sir, rather than more from the textbook. I visit rural clinics at Gajwal and Siddipet, and of recent, sir, at least 5 to 6 years down the line, I see the patients coming with people with dementia, the caretakers and the patients. I think it's on the rise, I feel. The particular reason I feel might be the awareness which is being created either directly through sources, or my one patient is trying to educate other patient to bring these patients. I definitely would request that first thing is the caregivers management is more important, as equal important to managing the patient, particularly people coming from the rural background. First of all, as Dr. Pawan said, it is very difficult even for them to come on a working day, to sacrifice their one day daily wage, and it is not possible for the patient to come alone with one caretaker. I think he needs almost 2 to 3 people to bring them all the way here. So it is like almost a big financial burden along with a consultation fee. And at this cost, the people coming there, I think it is our responsibility to spend time, I feel, first, because the caregivers need to be educated about dementia. Because, for example, in dementia, we see that the remote memory is intact and recent memory is lost. So many times we see that because of the burnout or because of the ignorance or whatever it is, we see that the caretaker feel that this person suffering with dementia is just acting or is doing wantedly, because the reason is they have the remote memory intact and the recent memory is lost. They tend to forget that it is a problem, the dementia, the recent memory is lost in the first go, and the remote memory is still persisting. So might be things like that. And in the first session, the psychologists and the psychiatrists, they really brought out so many things. I think these things have to be definitely be templated to the caregivers. the role of medication, and definitely the caregiver's advice. And on a busy working OP, it is worthwhile to spend time with the caregivers to educate them what is dementia and how do we go about. And always the victim is, because these people come from very low socioeconomic status, and definitely it's not no more. It's a myth. The dementia is on rise, and at least I'll be able to give data. And the rural population, the people are again, they are 70s, 80s, and there's vascular dementia, and probably when they can't even afford to get an CT or MRI done. So many dementias are at least we are able to diagnose, not able to subclassify the dementias, but I think we need to really educate the patients. And again, next thing is, sir, to just deviate from the topic, the financial burden is very high because many of the mobile vans which go to the villages to give them medications, there they have some antihypertensive, they have antidiabetics, they have so many other drugs, but the psychiatric drugs are almost very less. Then I think I see hardly little amount of olanzapine there, and again very difficult in the mobile vans. So even to give them the dose of donepezil or memantine is a big burden to the caregivers. And if you want to write any kind of medicines which are disturbing their behavioral issues, I think it's a big burden. So always I feel that, and I follow the dictum of Dr. Chandrasekhar sir, who always tells that we need to go slow and low in the doses because they work better than adding too much of medication and creating confusion. And the next important thing is, I think we should really take time to cut out the taboos and the misconceptions, because I see again people going around the faith healers, spending huge amount of money. They're almost bankrupt, and that's when they come down by a word of mouth, somebody saying that, you go to this person, I think she might help. And again, here we don't have the luxury of treating these patients with a psychologist to counsel them. And I think from today's session, I've learned a lot from the clinical psychologists. I think we need to really sit down and talk to them, or even we can train a person who has some basics, or even a person who has who can really communicate to the population to talk about the basic steps, how to handle these caregivers basically rather than the patients. And if you can do that, I think I have seen that happening, because the way they come with rage, they come with anger, they abuse the patient, they hit the patient, physical, verbal abuse. When you start to pat them, the caregivers, you just put your hand on their shoulder and tell them, boss, they're your parents. So you just understand this is the problem and I can't find a solution, but I can only say that these are the ways how you need to handle. Don't resort to expensive investigations. Don't try to go around spending money, but please follow the techniques that you spend time. See that he's better oriented or he or she's oriented, and don't create more confusion. And particularly the potty training, this becomes a big issue for the daughter-in-law because they suffer more and they have to lose their work. So we have to educate them that how these simple techniques can really help them in their daily life. Apart from this, sir, and it is like, I think we psychiatrists, at least it's my dream. I'm residing in Hyderabad, but I take time to go, like Chandani sir is our role model, Ashok Reddy sir is our role model. They have taken so much time. For years, they have gone to places where there is no psychiatric service. I think that's how we are doing. But I feel, sir, it is now time that we need to go even to the mandals and the rural population to spread this message. Apart from mental illness, the dementia needs to be handled, and the caregivers are the pivot in this handling of these patients. And all need not go for medical therapy, but in the milder forms of cognitive decline, I think basic counseling, educating the caregivers, I think it will give us a lot of results. We might be able to at least postpone the severity of the illness and reducing the confusion. And these are some of my takes, sir. Particularly, it is really, I'm continuing my services. It's really very feel good factor, sir, because the people stop going to these faith healers, spending useless amounts of money, and that's how we educate them. And these behavioral disturbances with little doses of divalproic sodium, little dose of risperidone, little doses of donepezil, memantine, or even little doses of lorazepam, clonazepam, they take us a long way. And quetiapine, mild dose, as I learned from Dr. Chandrasekhar, sir, 25, even 12.5 makes a major difference. And I think these things, along with medical management, many times even we have to handle the diabetics, we have to handle the blood pressure, because they are not in a position to go to the physician. I think here, I think we need to play the role of a physician, a neurophysician, and a psychiatrist. I think that's how the caregivers are more comfortable, and we can really reduce the financial burden. The stigma is reduced, and we can overall help the quality of life in this patient with dementia. So thank you, Chandani sir.
Yeah, so thank you, George. So what you're trying to say is that we need to educate the caregivers, and not only educate them, but be a friend to them, be a physician to them, be everything to them, the go-to person for them to handle, to talk about the different problems. Now, just a little observation I wanted to make about a common practice, cultural practice that we have for dementia patients. So with the families being spread out and brothers being in different places, and what happens is when a person develops dementia, because of the stress of the dementia is too high taking care of him, they all seem to take turns. You must also have seen several families where, for 6 months one brother takes care, then after 6 months a different brother takes care, and then after 6 months the third brother, because the daughters-in-law are not willing to take care of the person with all his tantrums. In such a scenario, what are the problems you encountered in such a this is a common cultural practice I've seen in my own practice, whether in Mancherial or in Hyderabad, you do come across such patients. What advice would you give in such situations, Dr. George?
Sir, basically, sir, I think very rightly you put it forward, sir. Basically, I always try to see that the entire family is there, because one brother or one sibling brings the mother or the father, and when they put these parents with dementia, and the environment is changed over 3 months, or even I've seen people changing it every month. So I tell them that you're only adding to the burden of confusion, because the change of environment, the change of caretakers definitely have a risk in increasing the stress. And all the siblings are not in the same financial condition. So I have seen in places where one of the siblings is a government servant, one is a big earning person, and the other person is just a farmer who hardly can take care. So first, I always advise them that all people come so that I can discuss with them about what is the prognosis and how you need to go about. I think with this, I can really bring the emotional connect between all the siblings. Basically, these siblings are divided based on their personal reasons. It could be finance, it could be land dealings, it could be so many things. But when it's coming to the parents, they start to realize that I think it is our parent. I think we need to really handle. And at the end, again, if they're on medication, I tell them, please see to that you are continuing the medication, and try to avoid frequent change in the caregivers, because it adds more confusion. And the last, sir, as you rightly brought about, sir, because this is typically happening in our rural community. Even one of the son is an ethanolic or alcoholic, it adds to the burden. Might be the anxious parents, they even turn to become more agitated, and where they're severely, brutally beaten, and all this thing happens. So we need to really talk about the entire family issue, and I think that reduces the burden.
Yeah, thank you, Dr. George. Nice points you have brought about the rural scenario, and the fact that caregiver stress is universal, whether it is in rural backgrounds or urban backgrounds. So we now need to think and discuss in terms of what can be done for the reducing caregivers burden, how we as practitioners can help. I would like to call upon Dr. Rajshekhar, Deputy Superintendent of the Institute of Mental Health, a very senior person with a lot of experience. Dr. Rajshekhar, could you just guide us about how we need to handle this caregivers burden, how we need to support them, treat them, help them? Dr. Rajshekhar?
Yeah, thank you, sir. Thank you very much, sir. So like what you have rightly pointed out, in the management of caregiver burden, what is very important is we have to get them, they should be prepared much in advance, like even before the illness deteriorates. they should be in a position to actually anticipate what is going to happen down the line, because we know that dementia is a deteriorating illness. We can just arrest, but we cannot completely improve the patients. I remember around 10 years back, I saw a patient at IMH. This 65-year-old man was brought up by his children. The reason was, for past 6 months, he was otherwise he was a gentleman, but for past 6 months, what he was doing is, he was actually, when his wife used to enter the washroom, he used to go to the backside of his house. He used to just imagine a 65-year-old man climbing trees, and he was actually peeping into the washroom to see what his wife was doing. So all these children thought that he was actually having increased sexual desire. But when we saw the patient and when we evaluated the patient, we found that patient had delusions of infidelity. He was having a lot of suspicions that a man was actually entering inside the washroom and they were having some sexual relationship. So what I'm trying to say is, we spent a lot of time to explain to the children that actually it was not increased sexual desire, but he was having dementia, and with associated DSPD, where he was having some psychotic symptoms, he was misidentifying people, he was having suspicions towards his wife and all that. So we should, early in the course of illness, we had to prepare the caregivers about the psychoeducation is very important about dementia, like what type of illness it is, how it is going to progress down the line and all that. And coming to the interventions, what is very important is, we know that caregiver burden is very high in all psychiatric illnesses, including dementia. Other psychiatric illnesses, at least patients improve. But dementia, definitely it's a long illness with a progressive deficit. So counseling or so-called therapies, cognitive behavioral therapies are very, very important even for caregivers, so that they can actually vent out their feelings and they can actually adopt better coping mechanisms and whatever things they have. And it is also important to educate the caregivers what they can expect from the patient. For example, we have to explain to them that there is a risk that patient can actually wander away. So it is very important for us to tell the patient, that caregivers, that they should take care of, in case patient absconds, how they can actually find out the patient back. For example, they can have some tattoos, something like, I was reading the evidence, tattoos wherein some phone number or something is written on their hands, so that if they get absconded, somebody can actually trace them out. And hiring a professional caregiver, Chandrasekhar sir was talking about that. Evidence shows that hiring a professional caregiver goes a long way in helping in reducing the caregiver burden. And extremely important is the support groups, the role of self-help groups, wherein the family members can actually share their problems with other caregivers who have similar patients with dementia. And active role playing, like coming to psychoeducational interventions, active role playing, wherein as therapists we can actually do a role play, and we can how a caregiver can perform the duties when dealing with a patient. And also important is stress management and teaching them active coping skills. So then there's something called collaborative dementia care management intervention. There are a lot of studies in this particular field. There are a lot of RCTs which has shown that, like what Chandrasekhar sir also was talking about, the management of caregiver burden is not at clinic, it is at home. So as a part of collaborative dementia care management intervention, the dementia care at home is delivered by qualified nurses who train the family members in dealing with patients with dementia. There is also very good evidence. For example, family members find lot of difficulty when a very old demented patient has a lot of difficulty getting into the lift. So there are some machines which actually help them in that process. I don't exactly remember the name of that, but such important things. And also we have to prepare them well in advance about the wills, the test, like down the line they may completely lose the cognitive abilities. So they should be in a position to give away their property. So well in advance we should prepare them. So what I'm trying to say is that legal support and all that is very important, and it is very important for them to know that dementia is actually covered under disability, and they get support from the government in this particular regard. And certain tips for caregivers is like, as usually talk about having breaks. A lot of time they have to spend on exercise, meditation, and all other things. And extremely important, I remember a lady whose husband was having dementia, and ultimately he succumbed. So even before 10 years prior to his death, she was actually depressed, and I had to put her on treatment. She was on Diloxin. So down the line, she could actually cope up with her husband's death. So timely help from mental health professionals is extremely important, and they should definitely take care about the future needs, especially the legal aspects and all that. Thank you, sir.
Yeah, Rajshekar. Yeah, just technical interruption.
Yes, sir.
Rajshekar, are you there? Are you here?
Yeah, I'm there, sir.
Yeah. What about the the problems with the professional caregivers? They also under a lot of stress. Not only the ones who are at home and taking care of as the home carers. A lot of guys, a lot of organizations are, lot of even businesses are offering home care services for people with dementia. There are a lot of dementia care centers where nurses and other staff work. What about the fatigue, and what about the burnout, and what about the problems in these professional caregivers? You would have anything for them?
I think it is extremely high, sir, but definitely it is. The logical thing would be definitely it is less than the one which is faced by the patient's family members, because the studies have shown that most of the caregivers are actually women and they are spouses. So what you said is absolutely right, sir. The professional caregivers burnout also is extremely high, but when they are taking turns in taking care of the patient, I think that is one way they can cope up with that problem. But they are professionally
Okay.
trained and they are qualified nurses. So that is what the evidence shows.
Thank you, Dr. Rajshekar, and thank you, my co-panelists, Dr. Pawan, Dr. George Reddy, for your inputs of your experiences in helping caregivers. I would now hand over to Dr.
Sir, with your permission, sir.
Yeah, George.
Sir, I think definitely our President, Dr. Minhas, and Dr. Vishal, the General Secretary, needs a special applause here, sir. Because I think Dr. Minhas is trying to spread psychiatry to the IMA. I think he is doing wonderful activities, because I think this is the area where I think our medical fraternity need to know the role of psychiatrists, sir. And regarding Vishal, the way he does activities to rural population, it could be dementia, it could be schizophrenia, whatever it is, he carries the banner, he goes around. I think that's a good part of our President and General Secretary. And Raghuram Reddy, sir, good evening, sir. Thank you, sir, Chennai, sir, for this opportunity.
Okay, yeah. Dr. Nitin, are you there?
Yes, sir. I'm here. I would like to hand over to Minat sir and Vishal sir regarding their inputs. Minat sir?
Minhas sir needs to unmute. Dr. Minhas bhai, you need to unmute.
I think sir is presenting his screen, sir.
Vishal sir, you would like to.
Yeah.
Vishal sir, we would like to have your inputs.
It's a nice webinar. Actually, it's a very informative and excellent session. I would like to thank all the panelists and moderators and office bearers. And I would like to thank you all for giving this opportunity. Thank you very much.
Thank you, Sumina sir. Any last words?
I think Sir logged out. He's going to join in his.
He's there, sir.
He's there.
Minat sir?
Yeah.
Any last take-home messages here? Your thoughts about the importance of the day?
The meeting was enlightening, and especially the caregiver burden theme, which is often neglected. We just talk about Alzheimer's disease and taking care of people having Alzheimer's disease, dementia, and we just talk about medication. But taking from today's meeting was psychological aspects, sitting with the patients, and various scenarios which were described today. I would like to share one of my example. My father, he is 82 years old, and he is suffering from the same disorder. Last time my mother and my brother brought him in railways, and he got suddenly at midnight he got up and he went to some other compartment. My mother and my brother were all lost. They didn't know what to do. They called me up, and we were lucky that we could find him. Someone else who has seen him with my brother and mother, we brought him back. So there are many real life scenarios which happen with patients of dementia, and lots of caregiver burden is there. Someone was saying that the caregiver should be perfect, but what I think is, even if the caregiver is not perfect and not very healthy or physically not very fit, still they can help people with dementia. Today morning we were having session at our college, Deccan College of Medical Sciences, regarding dementia, and I was talking to various faculty and the students over there, and I was telling them that not in our country but in Western countries there are nursing homes wherein there are 600, 1,000 people in nursing homes. All old age people are kept there, and during COVID time there was a huge problem. Many of them caught COVID and they died. Many of them had dementia. So luckily till now our country doesn't have that kind of thing. Like we tend to keep our parents with us, but gradually we will also start seeing nuclear families and both husband and wife working to meet their ends meet, and they won't have time for their parents, elderly parents. The expectancy is increasing, and there are many parents who will be staying back. So I think there will be need for lots of these kind of homes. Life expectancy in around 1900s was 47, but now the life expectancy in 2001 was 75, and now it is almost nearly 80 life expectancy. And as the people age, more and more number of people with dementia we are going to see and tackle. Even in India, we are finding many people having dementia. In my practice, 1 out of 10 are patients of dementia, and various stories of caregiver burden. A typical, I would like, if you permit, I would like to describe a typical example in our own city. Many a times, husband who's a breadwinner, he goes to Saudi. He is there in Middle East, staying there for 2 or 3 years. The old father and mother-in-law is not very well, or she has expired, and father-in-law stays with the bahu or the daughter-in-law. And many a times, disinhibition creeps in because of dementia, and many a times they are not able to express their feelings, the daughter-in-laws, and if they even try to express to their husbands or some sister-in-law who's staying far away, then they start accusing these girls, these ladies, daughter-in-laws, that you are not taking care of our father. Thankless job these caregivers have. The person for whom they are working or they are dedicating their time doesn't thank them because he doesn't understand. And people around who are not at the side, they also don't know what is happening. They just listen to complaints given by that patient of dementia, and it causes lots of caregivers burden. So good that we got 3 panelists who 4 people who talk about caregiver burden too. Thank you. Thank you, ARDSi. Thank you, Aster Prime. And I thank all IPS TSB members, IPS TSB PC, and IPS TSB office bearer for sparing their time.
Yeah, one point I would like to mention here, Dr. Rajesh here. 2 things in managing dementia patients, which is very difficult for our in our day-to-day practice for psychiatrists and practitioners like us. I have come across some patients who have intense sexual desire along with dementia. And even now I have one patient who has intense sexual desire, maybe due to some frontal lobe involvement or something. And it is very difficult to manage such type of patients who are already having dementia, but at the same time, they don't understand that they're causing problem to their spouse. And the caregiver, the spouse in this example, goes through a lot of stress because of that. And it's very difficult to manage the type of patients who have this intense sexual desire. And second scenario where it is very difficult to manage these dementia patients is especially during night, when they have these hallucinations, they try to leave the house. They forcefully open the door, even when caregiver tries to prevent the patient from going out. The patient is in very agitated mode and tries to go out of the house, and it is very difficult for the caregivers to keep an eye and watch the patient all throughout the night. So caregiver suffers from a lot of insomnia because of that. And we have many patients who leave the house and don't return back. And the family members have to lodge a complaint with the local police, and sometimes the patients cannot be traced again. So I think these 2 are the challenges in managing a dementia patient. Patient leaving the house, not knowing the whereabouts, not able to come back to the house because he is not oriented to place and he doesn't remember where exactly his house is. Because of the hallucinations he has, he thinks someone is calling or someone is trying to do something. Especially these hallucinations happen during the night time. So I think these 2 are very difficult to manage even after giving antipsychotics. As the previous speakers have mentioned, we have a lot of antipsychotics and we try to give all these antipsychotics. But even after giving antipsychotics and even after giving these medicines which control dementia, I think these 2 problems are very difficult to manage. And if any one of you can throw light on this and how to manage pharmacologically or non-pharmacologically.
Can you hear me? Yeah, Rajesh.
Yeah. Sir.
See, for hallucinations, we have to give antipsychotics. And sometimes you'll be surprised at the amount of high doses of antipsychotics that you need to give. See, quetiapine is something standard we all of us give because there's relatively less risk of Parkinsonism. But then with these kind of hallucinations, you need to go for risperidone or even blonanserin, also quite a good drug. any antipsychotic, higher doses will definitely control the hallucinations. I have dementia patients who have been receiving 300 milligrams of quetiapine and before the hallucinations could be handled. So you need to give the liberty to the patient's relatives to titrate the dose of the antipsychotics depending upon the hallucinatory level of the and the behavior of the patient. When it comes to sexuality, sodium valproate, I found it useful. I've also had this scenario, 3 or 4 patients I've had, and where we have added sodium valproate, their excitatory behavior has fairly been subdued and I've been able to manage with that. There were a couple of times when I contemplated giving them hydroxyprogesterone assisted, that is chemical castration, but I never had to reach that point. But yes, it is a common problem. We need to think beyond antipsychotics. Sodium valproate does a lot of help, in certain repetitive behaviors of patients, certain agitation and all that. George also was talking about sodium valproate. None of the speakers spoke about it. In real life scenario, 250 to 500 milligrams of sodium valproate do help a lot.
Can you go beyond 1 gram, sir?
It depends on how much the patient tolerates. The problem is in geriatric age group is the patient's level to tolerate the medications. And also, see, with that kind of 1 gram and 2 grams, you're likely to develop hepatic problems. And these people are very sensitive, and hyperammonemia and all these other issues can come in. So they generally need 500, 600 mg of sodium valproate. Rarely have I gone to 1000 mg.
But quetiapine at the dose of 300, sometimes it can cause postural hypotension, falls.
Yes. You have to build up. You have to build up the dose, not straight away. You start with 25, 50, 75, 100, till the point of tolerance. Never straight away 300, obviously.
Yeah.
And other antipsychotics also help. Blonanserin, I've given 4 mg, 6 mg, 8 mg. Surprisingly, relatively less anti-Parkinsonian effects compared to risperidone, and quite effective in the geriatric age group. Haloperidol, I'm a little cautious about giving haloperidol because they develop such horrible Parkinson's after some time.
Have anyone tried cariprazine?
No, I have not tried cariprazine. I don't know about the others in the group.
I think Prasad Rao sir has tried cariprazine. In one of his lectures, he was telling about cariprazine in dementia. Thiaprate by Intas.
Yeah, thiaprate.
Working well with abrasion and dementia. And as sir mentioned, some of the patients I have used Medrox 5 to 10 milligram, and it has helped. Though it is chemical castration, I don't.
In mentally retarded people with hypersexuality, that's the only best drug that is. In geriatric patients, I have not still tried it out. It has crossed my mind quite a few times.
Minhas, I have tried triaprade. It is really helpful. I have given 50 mg twice daily. Not only in dementia patients, especially in alcohol withdrawal, also it helps. Although it's not freely available, it is available at some select medical shops because Intas doesn't aggressively promote it. But it's an old drug, but I've been using it even now.
Lot of various but they to have their own
Thank you, Nitin sir. Respected seniors and colleagues, ladies and gentlemen, I am present here today with a profound sense of gratitude as we bring this enlightening public awareness webinar on behavioral and psychological symptoms of dementia to a close. On behalf of the organizers, I extend my sincere thanks to all of you who joined us from different parts of the country. We had a total of more than 300 participants registered for this webinar. General audience, psychologists, clinical psychologists, and counselors. Even we had psychiatry PGs who have registered for the webinar. Our heartfelt appreciation goes to our distinguished speakers, Dr. Sai Sudha, geriatric psychiatrist, Oxford NHS Trust, UK, and Dr. John C. Thomas, clinical psychologist, Aster Prime Hospital, who, despite the geographical distances, generously shared their expertise, research, and knowledge, making this webinar a source of inspiration and enlightenment for all of us. I want to thank the moderator, Dr. Chandrasekhar sir, Senior Psychiatrist and President of ARDSi, Managing Director of Asha Hospital, Hyderabad, for moderating the session. I want to express my immense gratitude to Dr. George Reddy sir, immediate past President, IPS TSB, Consultant Psychiatrist, Healthy Brains Mind Care Clinic, and Dr. Pawan Kulkarni sir, immediate past Secretary, IPS TSB, HOD of Department of Psychiatry, Chalmeda Anandrao Institute of Medical Sciences, Karimnagar, and Dr. Rashrekha Bipeta sir, a Professor and Deputy Medical Superintendent of IMH, Hyderabad, and the moderator of the panel discussion, Dr. Ashok Alimchandani sir, Vice President, IPS TSB, Professor and HOD, Apollo Medical College, Hyderabad. Last but not the least, I thank the IPS office bearers, Dr. Minaj sir, President of IPS TSB, Vice President, Dr. Ashok sir, Honorary General Secretary, Dr. Vishal Akula sir, Honorary Treasurer, Dr. Anita ma'am, and Dr. Fanikan sir, Honorary Editor, and Dr. Ram Subbareddy sir, IPS TSB representative to the IPS South Zone. We are equally thankful to all our technical team for their seamless execution and ensuring that this virtual gathering went off well. And furthermore, we express our gratitude to all our participants for their active engagement, thought-provoking questions, and enriching discussions in the chat. Your involvement has made this event truly interactive and dynamic. As we conclude this webinar, let us carry forward the insights and connections forged here to further the progress of medicine and psychiatry. And we hope you found this experience as rewarding as we did. Once again, we thank all of you for your unwavering support and participation. We look forward to welcoming you to our future webinars where the pursuit of knowledge and innovation continues. Thank you. This is Dr. Shivanu Pialla, Consultant Psychiatrist, Aster Prime Hospital, signing off.
Thank you.
Thank you.
Bye. Good night.
Bye.
Allowing us to be
Nitin will be thankful to do more and more programs.
Anytime. Nikhil.
And the entire EC also. All the EC people have cooperated and consented to give you this chance. And wonderful job, Dr. Nitin, Anup, and the team. Dr. Minaj, I think you did a wonderful job by giving them this opportunity. Worth the evening to spend with the caretakers and all the esteemed seniors and all the speakers.
Yes, enjoyed it. Thank you, Nitin. Thank you, Aster Prime. Thank you, ARDSi. And I thank all EC members, IPS TSB office bearers, past office bearers, and all IPS TSB members for their cooperation. Thank you, one and all. And I think we'll conclude this, not least, Dr. Raghuram Reddy sir joined the session and he was there almost for 1.5 hours. So we should learn from him. Thank you, Raghuram Reddy sir, and all of you.
Thank you, Pawan.
Thank you.
Okay, thank you. Hearty congratulations, Nitin and Anup.
Thank you so much, sir. Thank you so much.
My good night, everybody.
Good night.
Congratulations, Anup and Nitin and all the team for wonderful session.